It's time for DocTalk Radio, brought to you by Gilbert Hospital and Florence and Anthem Hospitals. I'm Dr. Ann Borik, board certified in internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being. Welcome to DocTalk Radio. Welcome to DocTalk Radio. Joe, how are you?
I'm great. How are you, Dr. Borik?
Good. Sponsored by Gilbert Hospital and Florence Hospital and Anthem. Today we have a special guest in the studio. Dr. John Stafford is here. Dr. Stafford, thank you for being here.
Good afternoon. Good to be here.
Good. You know, for those of you listening, today's topic is going to be focused on psychology. Dr. Stafford is a psychologist, and in a minute we're going to hear a little bit about his background and really what he does, and we'll be focusing on topics like anxiety and depression, and I think it'll be a great show. Anybody listening that wants to call in and join in the conversation, do not hesitate. Call in 480-745-1033. Dr. Stafford, tell us a little bit about your background and your practice.
Well, thank you, Dr. Borik. I've been practicing in the greater Phoenix area since 1994, having moved here from Michigan. And at this point, I have a couple of offices, one in north part of Phoenix and the other in the Northwest Valley, as we call it, out in Glendale.
Okay.
I'm also privileged at a couple of our hospitals in the area. I've been privileged at Arizona Heart for 12 years, and for almost 2 years now also Phoenix Baptist.
Excellent.
So I have some hospital-based work and some outpatient work.
Right. Explain a little bit about the collaboration between some of the medical docs and psychologists and really what you do in your practice.
Yes, well, of course, you and I met maybe 10 years ago when you were also working some at Arizona Heart, and so we've collaborated together. And one of the things that we've learned over the years is that people are whole people, and you don't suffer in just one way. I mean, if you're physically ill, then you can also get discouraged or depressed.
Right.
And some of the medicines that are used, let's say, for pain, have side effects that are mental health appearing side effects and that sort of thing. So it is becoming increasingly important, or maybe we're realizing it, that medical doctors and mental health professionals work together. Absolutely. In your opinion, let's focus on anxiety. We see a lot of patients with anxiety disorders that affect every part of their life, healing and health and well-being, unable to sleep. Maybe you can kind of shed some light on really what is anxiety, what do we mean by anxiety disorder, that kind of thing. Yes, well, just for a little context, in our diagnostic catalog of things, there are probably a dozen or so disorders that we regard as anxiety disorders.
Okay.
And the prevalence of those is amazingly large. A national study involving something like 8,000 or 9,000 Americans showed a few years ago that 24.9% of the American public, about 1 in 4, will have a diagnosable anxiety disorder sometime in their lifetimes.
Interesting.
So there are a lot of them. And so if you have 4 friends, odds are that one has an anxiety disorder or will.
Right.
There's a variety of these. Most people have heard of the phobias. They even made a movie called agoraphobia or arachnophobia or things like that. But there's also panic disorder. See people with panic attacks. There's people with social phobia. Man I had some years ago didn't dare go to his own retirement party because there were going to be so many people there. There's post-traumatic stress disorder, something that happens after you've been through a traumatic experience and then you have flashbacks and nightmares and that sort of thing. But the core for all dozen or so of these is anxiety. That's sort of the energizing internal thing.
If we were to say, define anxiety, how would you define it? I mean, just in terms of, just for us to understand. Is it a physiologic manifestation? Is it, the heart racing, sweating, or how would you define anxiety?
Well, since anxiety takes perhaps a dozen forms, the manifestation varies a little from one to another.
Okay.
If it's a panic attack, just to talk about those, panic attack will be an increased heart rate, and the breathing will get rapid and shallow, probably therefore experience of lightheadedness or dizziness. The palms of your hands can get cold and clammy. And panic attacks, they just defy rational understanding because they'll just hit you and there's no explanation. Like you'll sit bolt upright in bed at 3 in the morning out of a deep sleep, and you think you're going to die.
Right.
And in fact, many people who are having panic attacks end up in emergency departments, not unlike at the Gilbert Hospital, thinking they're having a heart attack. And you go through all the cardiac testing and so on, and you can talk about that. But in fact, all those tests turned out negative. It was a panic attack. It lasted about 2 minutes, scared the life out of the person.
Interesting.
But on the other hand, if it's a post-traumatic stress disorder, let's just say after, unfortunately, a rape or something like that, or I've had recently some Vietnam War veterans who saw a lot of death, who would themselves have died if they hadn't gone to the latrine and then a bomb came in and destroyed the bed they would have been sleeping in.
Oh my.
Then they'll have flashbacks, they'll have difficulty sleeping, they'll have nightmares, along with the physiological things like increased heart rate and that sort of thing.
And how do you treat that? I mean, what's the best way to approach somebody that has that problem?
There are multiple ways to treat it. Psychologists mostly use prevention, whereas physicians like you, I think, would use mostly intervention. So what we do, one of the things we do is we try to teach people how to relax. And there are skills at relaxing, and people can become good at relaxing. So just in the last 2 days, I've been involved in some relaxation techniques for people who need to calm themselves down in general.
Excellent.
So the panic attack doesn't have such a high level of anxiety going on.
You know, that's huge. And I don't know if you want to share anything, or how to relax. I mean, would you kind of tell us a little bit about how to do that?
That's almost like a cafeteria or a smorgasbord, because different things work for different people.
Right.
So there are breathing exercises. There are isometric muscular tensing and relaxing exercises. Not that the muscles themselves are the focus, but most people's brains don't know what relaxation actually feels like. I've asked any number of patients, tell me what relaxation is like. And they mostly tell me what stress doesn't feel like or something like that. They reverse it. But relaxation is actually a positive quality. And I know you've worked in that area because some years ago we talked a little bit about your Science Shido program, and you were working on that, and wanted the psychological component to be sound. I use visualization. Just yesterday afternoon, I had, this is unusual, a 13-year-old boy whose mother brought him in for anxiety. And I asked him if he'd close his eyes and tell me about the most relaxing place he knew about. And he described this make-believe island.
Interesting.
With a beach and a pier and a tree house and tropical fish. And he took about 8 minutes or so. I asked him kind of use all of his senses. And he was visibly more relaxed at the end of that 8 minutes.
Isn't that neat? That's huge. I think that we, from a medical perspective, need to really embrace that more, for our patients, for, preventative.
Right.
Joe, do we have a question?
Yes, we do. Our first caller, Sarah Williams from Atlanta, Georgia. Little background. She takes Klonopin for 9 years, 2 to 4 times per day as needed, 1.5 milligrams at a time. She takes Cymbalta and Wellbutrin. She has depression, anxiety, and the fear of leaving her home. The problem she has is when she doesn't regularly take the Klonopin, she starts to get bad headaches, almost to the point where she's going to faint, starts to feel very shaky, and then knows. She wants to know, is she physically dependent? Should she get off this? Or does it sound like she's on the right program for what she's got?
I want to just say that DocTalk Radio is really intended, not to treat people over the phone or over the radio or over the TV, but really to speak more in general. And so maybe we can approach that question just from a general standpoint.
She was really concerned if it's safe, or is this the dosages she's taking. She's concerned that could be hurting her more than helping her. That was her main concern.
With the Klonopin.
Well, that's more Dr. Borik's area than mine, so we'll interact about this. But there's a class of medications that we call benzodiazepines, and Klonopin is one item in that. And that class of medications is potentially habit forming. So the doctors themselves are being watched as to how much of this kind of medication they prescribe, because no doctor wants to set up a person to be dependent on a medication.
Right.
So with that long a history, I would be asking this patient to consult with a prescribing physician to ask that kind of question.
Absolutely. And it takes into account body habitus, how kilograms, how much they weigh, how, milligram per kilogram, what is the dosing. But in general, I would agree with you that benzodiazepine-type medications could potentially cause habit-forming, problems. And so you don't want to stop it cold turkey. I think that's probably a message that I want to get out to you.
Yes.
Absolutely check with your physician. You're on some other medications like Cymbalta and Wellbutrin, and there may be an interaction. So that's something to really talk to your doc about.
If not an interaction, at least the Wellbutrin is primarily a stimulant type of pharmaceutical. And so another part of the conversation with your physician might want to be the presence of a stimulant type medication like Wellbutrin and a calming type medication like Klonopin.
Right.
It may be that there are some adjustments possible to ease that.
So they may be working opposite.
They might be working opposite.
Yeah, so that may not be the best regimen for you, Sarah, is what I'm kind of hearing. Good, thank you for calling. Depression, people think that depression is the same as anxiety. What is your response to that?
Well, depression, the word, of course, refers to the mood, whether you're very happy, very sad, or somewhere in between.
Right.
And most of us spend most of our lives in between. We have some better days, some poorer days, but the poor days are not so frequent and so deep that it actually prevents us from going to school or going to the job or carrying on our personal and social affairs. But for some people, the depression does get that severe.
Right.
And let me refer to the base rate again. Sooner or later in America, this by the same epidemiological study, sooner or later in America, about 1 person in 6 will have a major depression.
Wow.
There is a genetic factor in this. If you have a first-degree relative who has been depressed, that probability goes up to 1 in 4, about 25%. So we know there's a genetic contribution to this, and if you like, in a bit we can talk about the contribution of genetics versus life experience. When I think of depression, I really diagnose that according to the manual. And the manual lists 9 symptoms, and I need about 5 for the diagnosis.
Okay.
Some are obvious to the public, but others are not.
Okay.
For example, a depressed mood is obvious to the public. But losing interest in your hobbies might not be so obvious. Poor sleep, poor appetite, low energy, being easily tearful, way overreacting emotionally to small things. Obviously, something like thinking about death a lot or a suicide attempt, the public would know about that. But I'm also looking at those more subtle symptoms, like the poor sleep, loss of appetite, loss of interest in things.
Right. Now, some people actually increase their appetite when they're depressed. Do you
Yes.
see that? Is that?
I do see that. And I think a lot of people actually try that because our life experience says if I'm feeling a little slow or a little down,
Right.
that double stuffed Oreo would help me so much.
Exactly. Well,
See?
chocolate is good for you, though, right?
Well, I can't disagree. But our experience is that if we get some fast-burning carbohydrates, like the chocolate or whatever, it'll perk us up.
Right.
I think, and you'll know more about this than I, but I think that actually makes it worse.
It can. It can bring you up and then down harder and faster. Right.
Yeah. Yeah. But yes, I see that. You know, the bag of Oreo cookies disappears faster when you're in a depressive valley.
Sure.
I must be depressed all the time. I'm feeling depressed right now. Be right back.
I'll get the chocolate out of the car, Joe.
That's good. Joe, do you have a question there?
We do. We have Les, 27 years old, from San Diego. He said he was in a car accident. It was fairly severe. He had 2 broken legs, a broken hip, and a skull fracture. And now, after 3 years, he's addicted to OxyContin and morphine tabs. Since his car accident, he can't work because of the nausea and sedation, and he's totally depressed. He wants to know, does he need rehab, or Is there a way he can get his life back together that you can recommend some other way besides checking into a facility?
How old is he again?
27.
Okay.
I think he needs a team. And one member of the team needs to be a pain management specialist.
Oh, and he did say he was in with a pain management specialist to get this, and he said he occasionally takes Flexeril for spasms. Mm-hmm. Sorry.
Okay, that's good. I'm glad he has a pain management specialist. That's one member of the team that he needs.
And his concern was it seems to not be going anywhere. Every time he goes, they just write the scripts. He gets the same thing, and they don't treat it all for the depression, and that's why he was going, what do I do?
Yeah. If there is, through a psychologist's lenses, a post-traumatic stress syndrome, and an accident won't always cause that, but if his sleep is disrupted, if he finds himself having nightmares about the accident, or if he reacts with great tension to, let's say, a vehicle of the same color that hit him or something like that, or going through the same intersection, then a psychologist can be a lot of help in treating that. And that involves some cognitive and some behavioral techniques of relaxation and getting that story out and kind of normalizing that sort of thing. And the psychologist would also be looking at what might be called triggers. What prompts this? Mm-hmm. Psychologists would be interested in helping him get to sleep well and be really relaxed before he goes to bed, rather than perhaps thinking about all the negative stuff which comes so easily to us, of course, when we're tired out.
Right. Mm-hmm. And I absolutely agree. A team approach is the way to go. There's some studies out now, just recently within the past week, validating acupuncture, for example. Would that be helpful, with some of the muscle strain and sprain and pain that he's experiencing? Instead of taking the Flexeril, maybe the acupuncture can be very helpful. Exercise, we cannot write off. Somebody 27 years old, that's had, multiple fractures, rehab is very, very important to strengthen the body from the inside out. So I think that that's something that will absolutely impact the depression state as well. And maybe you can talk a little bit about what exercise does in helping to elevate mood.
Oh, yes. Exercise is good not only for the muscles, for strength, and for muscle tone, and it's the right kind of exercise for flexibility as well. But exercise also produces the kind of neurotransmitters that brighten our mood.
Serotonin, dopamine.
Yes.
Absolutely.
Yeah, epinephrine.
And epinephrine. Dopamine, actually cortisol levels go down. And that's important for you to hear in this whole process. To start out with water, maybe water therapy. If you've had a fracture and, your leg, broken bones in your legs and a skull fracture, water therapy, aqua therapy would be a great modality to start with.
Right, because water is not only buoyant, so you don't have to do the weight bearing, but it also provides resistance, so you don't have to move very fast without the muscles running up against that resistance and therefore getting stronger.
And getting stronger, exactly. So those would be, our recommendation. I don't know if you'd add anything else, but I think that's really the way that I would approach it.
That would be the core of it, yes.
Good, very good. Let's continue to talk about depression. Bipolar disorder is a buzzword. We hear a lot of it, and I just kind of want to have you talk a little bit about, the definition of it. What is it? Does it fall under the category of depression?
Well, that's a really cutting-edge question, and maybe you knew that, because our thinking on the bipolar disorder is currently informed by some exciting new research that's going on in Nashville, Tennessee, and Atlanta, Georgia, not much of which is published yet. But to step back from that and just talk about the bipolar disorder, if we think about a depressive disorder as being a series of deep valleys, then you can also imagine that for some people, in addition to the deep valleys, there are these spikes of euphoria in which the person doesn't need much sleep, has lots of exciting ideas, probably behaves with too much enthusiasm, whether it's spending money or traveling or things like that, or involving some risky behaviors. Typically with a bipolar disorder, this always sounds strange to me when I say it, but there are more valleys than there are hills. So there will be more periods of depression, and then every now and then a euphoric, manic kind of high. That would be a bipolar disorder. Most people do not go to their doctors to complain that they are feeling too good. I've never yet had anyone come in and say, Doc, I have all this energy. I'm going to be this great star and make a whole pile of money. And I don't need much sleep, so I can work like 18, 19 hours a day. Help me. Nobody ever thinks he needs help in that state. So the manic highs get missed. And on average, a person with a bipolar disorder will go through 6, 8, 10 doctors before getting the right diagnosis. And therefore will often get an inappropriate medication, first off, because the doc thinks it's just straightforward depression. The bipolar disorder has become, in my mind, popular because some prominent in the public eye people, newscasters and so on, network people, have acknowledged a bipolar disorder. So when a person comes to my office, either on her or his own or brought by a family member and says, I think I have a bipolar disorder, I'm a little skeptical. And I want to go through the diagnostic screening myself, because mood shifts are not bipolar. A happy day, or going from one mood to another quickly, that's not typically a bipolar disorder.
Interesting.
So you have to screen it to make sure you're really looking at that.
Is there an age predisposition? Do you see, young people, older people? What is the mean, or is there?
My experience on that's pretty limited, because mostly I limit myself to age 16 and up, late
so
adolescents and adults. But we're cautious about diagnosing something like that, especially something major like that, during childhood or adolescence. We really want the person to be at least late adolescent, young adult, before settling on a diagnosis like that.
Very good, very good. John, are there any foods that you can think of off the top of your head that that may make depression worse, or anxiety, or any of these symptoms worse? Do you tell your patients to avoid certain things like caffeine, or is there anything that you would recommend just for our general listeners?
I think I do more with which foods to avoid
okay, right.
than foods to use. I consistently recommend a nice balanced diet. And if people have nutrition or weight issues that might be related to a mental health condition, I say move to a diet that you can live with forever. I'm not a fan of diets that are temporary, run a few weeks or a few months. The base rate on those is that about 8% of the time they're successful, and 92% they're not. So move to a diet you can live with forever. Portion control is a big key. Now, obviously, if you have an anxiety type disorder, you want to avoid stimulants. So colas, coffee, chocolate, unfortunately, are kind of contraindicated if you have an anxiety disorder. There are some things that you can take that will calm anxiety. For example, we know that chamomile tea has calming properties. So that would be something that someone could use.
Yeah, and by no means would you recommend the Red Bull or some of the energy drinks in people
No.
that have anxiety disorders and that kind of thing?
Well, actually, I'm mostly in favor of people getting their calories from solids rather than liquids anyway. I just think that's better overall. But no, the energy drinks and so on would not be a good choice.
Okay. St. John wort, can you comment on that at all?
Yes, I can. St. John's wort, while we don't have the same kinds of placebo-controlled double-blind studies, just to use the jargon, that we have for indicated medications, seems to work pretty much in the same way that our prescription serotonin agonists work. And it's an herb. It's used in Europe far more widely than it is in the United States. And I've seen it work successfully for mild to moderate depression. I have not seen benefits for people who are taking it for a really major depression. But for the milder things, and very few side effects, almost without a side effect profile.
Very good, very good. So it's safe?
It's safe. The thing you have to think about with St. John's wort is that you care about purity and freshness in the same way that you would care about purity and freshness in the vegetable fruit aisle of your grocery, because it's controlled as a food, not as a medicine.
Can you grow St. John's wort? Is that an herb you can grow, or?
I've never tried that.
I don't know. That's a good question. Yeah, I don't know.
Maybe someone out there does know.
Right.
Maybe someone's growing it
Let
for
us know if you grow St. John's wort.
Yeah, that would be good.
We do have a couple of callers right now. First one, Marty from our hometown here. Marty Felix from Gilbert, Arizona. Said, I never thought of depression, but since I turned 40, I'm now 43, I don't have the desire to get up. I sleep a lot. I hate to go out. I've gained 40 pounds. And I don't mean to laugh when I read these because I think of myself sometimes. Maybe I'm, when I leave this show, I'm manically depressed. I've got every symptom. So let's see. I hate to go out, gained 40 pounds. Never really happy, but I have a good family life. I take no pills. Is this a normal turning 40 thing and getting older, or do I need to see a doc?
Very good question. Mm-hmm.
Psychologists often think of our human lives as going through a series of stages. And each time we move from one stage to the next stage, a certain amount of adjustment, even major adjustment, may need to take place. So let me go to a different stage from Marty's at the moment. One of the most obvious stage changes would be going through puberty when we develop physiologically that way. And that change is obvious, and there are a lot of secondary sexual characteristics that change and so on. And we've all learned that there can be some chaos around that. Mm-hmm. Well, there's another change from one stage to another, from early adulthood to middle adulthood, typically occurs in your early 40s. It has historically affected men more than women, but the more we have women in all of our occupations and thinking about careers, the more we kind of see it in women too. The public knows of this as a midlife crisis. So it could be a good excuse for you, Marty, to go out and buy the red sports car, as long as you don't drive it too fast, and stuff like that. But what's really going on here, seen through a psychologist's lenses, is kind of a reconsideration of where your life has been, what's meaningful for you now. You probably look around and see guys who are earning 50% more than you are, and you realize they're not 50% happier. And so you're asking yourself, what kind of is the meaning of this, and which way's forward now? Now, there may be some, you don't have information about other life events, but in your 40s, sometimes parents become dependent on you, mm-hmm. or pass away, or there's some major losses and things like that. We can't discount external stressors of that sort.
Sure. Mm-hmm.
I've come up with an innovative solution I think that may work. It's a little bit alternative lifestyle, but what about if you're feeling depressed over 40, and every time you're feeling depressed, you turn to maybe your partner or somebody, and they give you like $100? Would that help?
Can you find the partner?
I guess you're right. There's the problem.
Probably
didn't work too well, huh? Mm-hmm. Can we get to Cynthia from Abilene? Let's see. I have been diagnosed schizophrenic. I don't think I have it. My friends tell me. I talk to myself and sometimes scream out loud. But I don't notice doing it myself. When I drink on my medications, I black out every time. That was the end of that. That's what she wanted to express.
Well, Cynthia, I want you to be working with a professional. You need a psychiatrist for something like schizophrenia. And you need to be confident that you're working with a doctor who is good at what she or he does. So that's step one. If you're skeptical about the diagnosis, then that's something to talk over with the doctor. Now, I'll let Dr. Borik comment, but I already get uneasy when someone says, I use alcohol and take mental health medications, mm-hmm. because that's kind of a big no-no.
It really is. It really is. And when you say you black out, there's vasomotor symptoms that occur. The blood vessels dilate and then constrict, and you can pass out, and blood pressure can fluctuate. So we adamantly recommend that you do not drink alcohol while on any psychotropic medication because of that. And and if you continue to do that, then obviously you're risking passing out, falling, breaking, bumping your head, breaking a hip, those kinds of things. You're also putting yourself at risk in terms of the health of your liver. Absolutely. And again, this is more your department than mine, but mm-hmm. When I see a patient in a hospital, one of the things I always look at under the laboratory tab is how well is the liver functioning. That's exactly right. And if you're drinking and using these medications, both of which are metabolized in the liver, you're putting a load on the liver that could be excessive. That's exactly right. So I would be very, very careful. The outbursts, that's something that really needs to be addressed by your doctor, because there are different diagnoses. There's Tourette's, and there's other things that possibly might be going on with you that may not be schizophrenia, and that's something that should be looked at.
Or there may be more than one thing going on.
Exactly.
It could be schizophrenia plus or something like that.
Exactly.
Yeah, the brain does have something I just call the management center. It's the part of the brain that's under your forehead. And when you drink alcohol, you tell the management center to take the evening off.
Very good way to put it.
And that's not a very good thing to do.
That's it uninhibits you, and
yes.
And that can be a problem. But thank you for that question. That's interesting. That's good. Let's talk about alcohol for a minute.
Yes.
In terms of your practice, I mean, we recommend no alcohol with any psychotropic medicine. But there's some studies out now saying that a little bit of red wine is good. How do you balance that in your patient population?
Well, the first thing I do is I divide my patient population into two groups. And the one group is people who should not drink at all anyway because they're vulnerable to alcoholism, and that's about 1 in 7.
Okay. Wow.
Which is a higher number than most of us
It
realize.
really
But
is,
about 1 in 7 Americans is vulnerable to alcoholism, and that one person should just regard alcohol as poison. Now, for the other 6 out of 7, it's a more complicated question, because alcohol does have benefits. It helps you relax, and relaxation is good. Obviously, excess is not good, but relaxation is desirable, and wine, especially red wine, has some qualities that can foster good health. The issue for those 6 people out of 7 has a lot to do with liver function that we were just talking about, because the alcohol, your liver's going to prefer the alcohol to the medication. Is the way that works. See, right. So you drink the alcohol, and then the medication hangs around in your system longer.
It's not metabolized.
And then you've got a dosage problem with the concentration in your bloodstream.
Right.
Not being well monitored, not going the way your doctor wants it to go.
Exactly. And that refers back to the question about Klonopin, that, maybe the medication is hanging around longer, and that's a problem. And it interacts with some of the other medicines, so you've got to be very, very careful. People may ask, well, how do I know if I'm the 1 or if I'm one of the 6? How do you know? There's a hereditary component.
We can't track it to a particular place in the hereditary string, but all of the evidence says that alcoholism or other addictions have a genetic component. So one of the things you want to do is just look around your family and say, do I have a first-degree relative who's had an alcohol or drug problem? If the answer is yes, okay, amber light starts to flash for you. And if you're surrounded by it in your family, just don't drink. You can live a lot of years and never have a drink. It is not essential.
Right.
But for the rest, it's easy to say experiment, but I mean, every young person I know has experimented with alcohol anyhow, even from some very cautious families about that. So I don't want to encourage experimentation, because that, in principle, is probably kind of a risky thing. But you can gather enough information from your family, or very small quantities, and if you pay attention to how you feel, you have the information.
Then the answer's there. Very good. Joe, you have another question?
We have Rich from St. George, Utah. He says, I am bipolar 2. Is this a farce, or is 2 a real illness? What is 1? I was diagnosed yesterday and given a handful of pills. I wish I could get a second opinion from you. I really enjoy the show. But he's in St. George, Utah, so...
Well, he can't get a second opinion over the radio in any way, because the doctor is going to want to see the patient in order to give a second opinion, or any opinion. But I can say a few words about bipolar 2. And you might, if you have a scratch pad, just draw a little grid, a 2x2 grid. Bipolar 1 means you sometimes have this full-blown mania that is so exciting and so wild that you lose touch with reality. And you also, from time to time, have this deep depressive valley that is really deep and immobilizing. That would be bipolar 1. But sometimes we get the fully deep depression and only kind of a junior high mania. So that you have these excited periods, but you never really lose touch. You don't get really wild. That's bipolar 2. And that is now in our diagnostic manuals. When the next diagnostic manual comes out, it will probably show also the bipolar 3 and bipolar 4, because those are in the research literature, and that would be the full mania, junior grade depression, or junior mania, junior depression.
Okay.
So it fills out your 2x2 table.
Interesting. In your opinion, is one more common than the other in terms of 1 and 2? I mean, have they been able to identify?
I don't have data on that, and the bipolar 2 diagnosis is relatively more recent.
New. Okay.
My experience is that in an outpatient practice like mine, I really can work with a person with bipolar 2 because the manic part is not so extreme.
Right.
Whereas if you have bipolar 1, it's harder to work with on an outpatient basis, and you almost more certainly need a medication, pharmaceutical help.
Interesting. Okay. Very good.
Terry, Muncie, Indiana. She says, I'm totally afraid of the dark, and it's driving my husband absolutely crazy. I've tried to sleep with masks on, but they give me claustrophobia. Is there anything I can do to help with that?
Okay, so now we're working on a partner relationship issue. Well,
She said she has to sleep with all the lights on.
if she has to sleep with all the lights on, it's going to be a real challenge. I think, first place, find a good psychologist there in Indiana, because you can work with that. And my way of working with that would be start with all the lights on, and then just gradually ease back the brightness and see if she can make some adaptation. I did have a patient years ago who could not sleep in the dark. And the reason she could not sleep in the dark is she had been raped in the dark during her adolescence. So this made sleeping with, now that she's an adult, her husband, and enjoying the benefits of that relationship a difficult thing. What we did find is that if she had a nightlight in the room that didn't illuminate the whole place, but gave her enough light so that she could see where the door was and the window and the closet and so on, that was enough to calm her fear and let both of them get a night's sleep.
Interesting. That brings up phobias.
Yes.
Maybe you want to talk a little bit about phobias, because I think there's a lot of different phobias, and maybe you can bring some clarity to the confusion of what is a phobia.
I'm not sure I can, except to say that a phobia is this intense feeling of anxiety in the presence of a specific
Trigger,
thing,
right?
Specific trigger, and that trigger could be anything. So claustrophobia has been in our catalog for a long time. I think it might disappear with the next diagnostic manual. We have a new diagnostic manual coming out in, I think, the spring of 2013.
Okay.
But in any event, people know of claustrophobia. That's being afraid of being closed in a small space, like being in a closet, something like that. But anything could be the trigger for a phobia for you. I treated a farm girl one time from Iowa who had a phobia of mice. And when you live on a farm where they grow corn, mice are part of your world.
Right.
And so mice were in the barn, of course, and in the silo and in whatever, the corn crib, but they were in the house too.
How do you treat that?
Oh, you get a couple cats to go kill the mice.
To get rid of the mice, right.
if you live in that farmhouse. But yes, I would start with any phobia. I would start with general relaxation, so I knew the person had picked up relaxation skills. And then I would take that relaxation into the phobic area. My best example goes back to my days of college teaching. I had some students who had what we call test anxiety. Bright students came to class, paid attention, did their homework, prepared for the test, and they come into the exam room, which was, of course, anxiety-producing setting. And they'd see a question, and they'd know they knew the answer. They could even see the chart on the right-hand page of a book with a certain black type, and they just could not come up with the answer. So they'd have to blank. or just filled in something random. Get out in the hallway, and before even opening the textbook, said, "Oh, I know what it is."
Right.
But of course, Dr. Staper won't let me come back in because he'll think I looked it up. So they come to me a week later after getting their C pluses and say, "Doc, you got to help me study this." And I'd get these stories, you know, and I knew that the information was in that student's brain.
Right.
It just was inhibited from coming forth in that pressure situation. So I said, "I don't need to teach you psychology. I need to teach you to relax." So we would go through this visual exercise. Takes about 6 sessions. You can even do it in a group. And you get them to imagine being in the dormitory room and get them really relaxed. Scale of 10, they're down to a 3.
Right.
Now let's imagine going down the stairs and walking out to the sidewalk in front of the dorm. Still relaxed? Let's walk over to the classroom building. And we make successive forays toward and then back away from that test room. And sure enough, I got an average GPA rise, not grade in psychology, grade in the transcript of 1.5 grade points from teaching relaxation for test anxiety.
I mean, that's huge.
Oh, yeah.
Yeah.
That's going to grad school or taking a job at the garage.
Getting into medical school. I mean,
Yeah.
really, that's interesting. What I'm thinking in my mind as you're saying that is white coat syndrome. People who
yes.
have elevated blood pressure when they come into the doctor's office and it's just off the wall.
I know, I see in your white coat, my blood pressure rises.
And the blood pressure rises, right.
Yeah.
And I think that relaxation techniques, same thing, would be very beneficial, you know, for those people.
Sure.
That's interesting. That's really good stuff. I know we have some more questions. John, anything else you wanna add while we're waiting for the next?
I think maybe we've touched the phobias enough. There may be something else our listeners want.
Okay, good. Just in terms of general information to our patients for general health, what would your recipe be? You know what I'm saying? And somebody that, let's say, you know, is having a bypass surgery or, you know, major hip surgery, in order to keep that post-op time mentally stable, what would you recommend that be done? You know what I'm saying? Kind of.
Yeah. Well, if I understand, then my answer will make sense, and otherwise you just ask me again. I focus on about 5 really fundamental things. I say you need good balanced nutrition. You need exercise. You don't need to be heroic, be an athlete, but you need some kind of regular exercise. You need good sleep. Okay. You need social relationships. Some of us need, you know, larger numbers of friends and larger gatherings, and some just 1 or 2 close friends, but you need that. And you need to take care of yourself spiritually. You need to be nourished with something that speaks to you. That could be religious, or it might be something else, but maybe it's music, maybe it's reading or something like that. But if you've got those 5 things going for you, you've got a lot of resilience. Anything you can do to thicken up your resilience before surgery is going to shorten your recovery time.
Interesting. That's very, very good advice. Question?
We have Mark Peterson from Phoenix. Says, I have a vet buddy that sometimes tells me stories that are just incredible. Like, for example, he works for the president, he's head of the FBI, head of the CIA, he's dating supermodels. I really think he's sick. He doesn't think he is. What should he do?
Well, I guess the question is what can Mark do? And the
yeah,
fact
right,
is,
exactly.
His buddy is not going to go to his doctor saying, "You got to cure me from dating supermodels."
That's true.
There's no doctor that's going to say that. Obviously, unless these are verifiable things in his buddy's life, there's a problem there.
He said it's a constant, and none of them are true. He's known the guy since he was young.
He's fabricating.
Completely, total. I mean, he'll go off for hours on these stories, and he really believes them. He said his friend believes them.
Well, if those stories are discounted, then obviously this person, his buddy, is living in some sort of fantasy world. He apparently is not suffering a lot from it. So I would be waiting for an opportunity when he kind of came down from all that excited, euphoric life. There must be times when he could talk more or less in touch with reality and take advantage of those times. But, you know, the friend is presumably an adult. Adults are presumed to be competent. None of the rest of us can just intrude on that and say, you have to take help. it's a free country.
That's interesting, when you really think of it that way. Is there anything that you would recommend doing from what you're saying, this person probably is not suffering and really there's nothing to help. Is that what you're saying?
The person himself is not subjectively aware that anything's wrong.
Very good. That's interesting. Anything else?
Tina Maria, Worcester, Massachusetts. She says, I have these phobias. This was when you were talking about phobias. Driving, tight spaces, snakes, bugs, being touched, germs, crowded rooms, and doing dishes. Is there a pill or medication or a program you can recommend to get rid of these phobias?
I'll let Dr. Borik talk about the pills. I would think in any focal experience of anxiety, we have medications that are good for short-term use, and I'll ask you to say a few words about that in a moment. But there are some medications that you could take that you could take indefinitely too in that area. But there are programs. One goes often by the label of systematic desensitization, which is a psychological procedure, and you can work with phobias on that. Any relaxation strategy that works for you, you just have to try them, because one thing will work for one person, another for another person. But if there are this many phobias, then this tells me the general level of anxiety throughout your life is too high. And you're overusing those neural circuits, and you can wear them out. You can think of it as inflammation of neural fibers.
Interesting.
And it is not good. So the more generally you can lead a calmer life, even giving some valleys of relaxation in the day, and making sure you're really relaxed before you go to bed, that sort of thing, will be helpful.
Right.
And then you can talk about the medications.
We use benzodiazepines sometimes, Xanax or Ativan or something like that for short term, just to help kind of intervene until they can get more of a long-term therapy regimen.
Right.
Music is very therapeutic.
Yeah.
We know that there's studies now looking at the beneficial health benefits of soft music, but that's not going to do that's not going to take care of it.
It didn't get to the issue.
It's not going to get to the issue. No. That's why, in the hospital we use benzodiazepines.
Because the
Xanax.
patients there are presenting now in real misery.
Exactly.
But you probably also think about a serotonin agonist, Prozac and its cousins.
Yeah, the Celexas and
because
the
you can take that long term. You can't get dependent on it. And the FDA has approved most of those serotonin agonists also for some form of anxiety.
Right. And so that's exactly what what we would recommend.
That's the premier treatment.
Smoking. Do you have any comment about how smoking does it have an effect on escalating anxiety disorders, or does it calm people who are anxious? Or it would just be interesting to know what your thoughts about that.
Well, of course, I'm supposed to say that smoking is bad.
Right.
What I think about that in a little more detail under that overall title is that the nicotinic receptors are actually pretty important, but smoking is a bad delivery system. And some people's nicotinic receptors apparently are more sensitive than others, and one has to care about that. But I think smoking in general, it has so many more negative effects than positive that if you have to address nicotinic reception, there'd be some other way.
And that's what I'm getting at. Do you ever in your practice recommend a nicotine patch, for example? Or nicotine gum or something like that?
Well, I certainly recommend it in a hospital where you don't want a patient lying in a hospital bed smoking in your hospital room. So you're not going to permit that at your hospital or any other. So then you have to think about something like a nicotine patch.
Right.
Actually, a fairly good friend of mine, whom I met as my real estate agent 18 years ago, was absolutely hooked on cigarettes. Now he's hooked on Nicorette gum. And it handles it for him. And I think that's, if he needs that, at least he has a source of nicotine that doesn't mess up his lungs and shorten his life in that way.
Exactly. Interesting. That's good. Joe, do you have some questions there?
We do. Alan from Toronto.
Canada.
Toronto. He said, generally, I am a very calm, very well liked in the community and has a great family. But sometimes, just for no reason whatsoever, he'll just blow. Throw things, hit walls, throw pots and pans down, knock over furniture. This may last 5, 10, 15 minutes. His wife thinks they need marriage counseling, but they don't really have any issues with their marriage. He just flips out, and then just like he flips out, he's fine, and he's apologizing because there was no apparent reason why this even happened. He says, "Do you think marriage counseling is the way to go, or do I need something else?"
Well, he certainly needs something else. I can't rule out marriage counseling depending on just how much of an issue this has become. And it might merit a look by a neurologist, because this is abrupt, fairly brief loss of neurological control. His brain ordinarily controls this, and then every now and then it loses control. And a neurologist might be able to find something.
Is there a seizure activity?
It could be a small seizure activity or something like that, and a seizure gets triggered by whatever. So that's one thing. But if that is ruled out, or the neurologist takes care of the neurologist part of that, then I'd be asking Joe's wife, do you think you know this is going to happen before Joe knows it? Because, see, people who are close to each other, who live with each other, pick up subtle little signs. They'll see the eyes squint a little bit, or they'll see a nervous little tick happening, or they'll feel the pitch of a voice rising maybe a quarter step or a half step. And they might not be able to tell you what they're picking up, but they feel it because they're just so familiar. And if the wife says, yes, oh yeah, I think I know that, then I turn to Joe and I say, Joe, how do you like it that your wife knows something more about you than you know about yourself? And so far, none of the people I've asked that likes that too. Somebody else knows more about them than they know themselves. Now, if I can help that couple become a team so that Joe gets an earlier warning that this might be coming up, then maybe he can do some things to intercept it. Because you can't intercept it when the things are flying around the room.
One of the things that I would want to ask, is there a food allergy? I mean, is there something that triggers it? Is there something that maybe he's eating that can trigger it? And I don't know if you would agree with that, or if that's on track with a psychological assessment, but I think we need to keep that in mind as well.
It's outside my area of expertise, but I think you're probably right. Yeah.
So is there something, and that's something that I would want to ask Joe. Keep a diary, when in the day. Is it after you eat a certain thing?
Right.
And if it is, that's an easy fix.
Or do they always happen in the evening when you're tired?
Right. Is it cheese? Is there something that maybe can increase, certain chemicals in the brain and those kinds of things?
Yes.
Right. I think that's important. Fatigue, insomnia, sleep apnea. I don't know how much you see patients come to you that basically have undiagnosed sleep apnea. Is that something that you deal with at all? Because we see a lot of it. We see a lot of people in the hospital with different, elevated blood pressures or feeling depressed. And then when they get a sleep study, and when we treat them and they get a good night's sleep, that depressed feeling, that anxiety goes away. Is that something you see?
Well, I certainly see people with sleep apnea. I don't diagnose it because you need a sleep study, but I've referred people to sleep centers for those studies. And it is very worth treating that, because if it goes untreated, you have a number of secondary effects. I mean, like you lose brain cells and stuff like that, and you could give yourself hypertension and all. So it really is serious. The sleep apnea, of course, is more likely with obesity because you lie down and that airway is more crowded. It's also more likely if you have alcohol before you go to bed, because that relaxes the tissues too. So you're more likely to have a snoring problem or apneic problem if you've been drinking before you go to bed.
So I guess what I'm getting at is people can be diagnosed with depression when in fact it's really undiagnosed sleep apnea.
Yes, yes.
Okay, good. Other question, Joe?
Actually, we just had a comment from Russ out of Newark, said, what a great show.
Good, thank you. Great.
I will say, if you're pausing here a moment, one of the things that I have done for the last 8 or 10 years is the psychological screenings for a group of bariatric surgeons.
Interesting.
These are the docs who do the gastric bypass or the lap band or the sleeve. And by the ethics of that surgical specialty, they have to have a psychological clearance to go ahead. And the patients almost universally resent this requirement. But, you know, there's some things that you want to rule out. For example, there is such a thing as an eating disorder. And surgery is not going to cure an eating disorder. You know, so it's important to rule out stuff like that.
That's great. That's
See?
interesting.
So necessarily, we do get a thin stream of patients in our office whose weight is 50%, double, 2.5 times what a healthy weight would be. And of course, among those, sleep apnea is really quite prevalent. Yep.
So just getting back to finishing that thought, number one, why, in your opinion, do they require a psychological assessment? You know, if you do diagnose an eating disorder, how do you treat it? Do you not recommend surgery, or how do you deal with that?
Well, you know, there are specialty centers for treating eating disorders, and a referral for a specialist, and that would be appropriate. And I have a couple specialists in eating disorders to whom I would refer. But we also look at how the weight was gained. Is it a response to stress? Are people overeating just, you know, the comfort food? Give me some more of the mac and cheese because I'm feeling kind of down this evening.
Right.
What kind of lifestyle change is this person going to have to make? Because the surgery is not a cure for obesity. Surgery is a tool. And after the surgery, the patient has to use the tool to lose the weight. So we spend significant time trying to figure out what types of lifestyle changes are going to be appropriate. Otherwise, they'll just spend the money, go through the misery, and defeat the surgery.
And so continued treatment for that disorder is recommended?
Yes.
Thyroid function. You know,
thyroid
making sure
function, another thing. Sure.
Right. Very good. Do you believe we're almost out of time?
This has been wonderful.
This hour has just flew. Yeah, we're just about there. Joe, anything else before we wrap it up?
We're caught up this minute.
Good. We've had some really, really great questions. Those of you out there, thank you so much for calling in and joining in the chat. You know, just to wrap this up, let's just bring just to summarize the show. And I really wanted to repeat again what you said about the 5 components. Anybody out there that is heading toward an elective surgery, for example, hip surgery, heart surgery, bypass, or just interested in general health and wellness, the 5 things that Dr. Stafford alluded to is good nutrition, exercise, even if it's just minimal exercise, even if it's just movement. You know, we know that movement is medicine. Good sleep, and, you know, at some point we can talk more about that. Good relationship, you know, within family, friends, and a good spiritually fulfilled life. I think that's really very, very important. Anything else you want to add, John, before we close?
Well, I'll add that not only is it enjoyable to have this kind of conversation across disciplines, but really this is the way health ought to be pursued in a multidisciplinary, integrative healthcare kind of way. We've gotten so specialized in medical care and in psychology that sometimes it's difficult for us to talk with even very close colleagues. And it's really an important kind of conversation to have. It's also the case, I was just visiting this morning with a person, pointing out, not a criticism of you because this doesn't apply to you, but so many physicians want their patients to be sick in just one way. Or the presenting problem comes in, Doc, I'm suffering with this, and you focus almost microscopically on that, and then you lose sight of these other things that are probably connected. So doctors who can talk a range of vocabulary and doctors who like complicated things are really a plus. And I think we need to move toward that.
Absolutely. You know, at Gilbert Hospital, Florence Hospital at Anthem, which is where I practice, you know, our vision, our movement is really toward that, to really embrace more of a multidisciplinary, not only treat, and I always say it, and I think people have heard me say it, that, you know, we're not just ministering to the physical body, but emotionally, spiritually. You know, it's so important. And so thank you for being here and kind of filling in that piece. I hope to have you back again, and maybe we can do another, you know, there's so much more to talk about,
oh, yes.
You know, from a psychological standpoint. Joe, I think that's it. Anything else we need to... addressed?
We're good.
Okay. Just I want to put out there our Facebook page. Please, if you haven't checked out DocTalk Radio, come on, like us. We're kind of tracking that. We have a website, doctalkradio.com. So check it out. And we have all of our show, the clips from our show here is on a YouTube site on our website. So I invite you to check that out. And next week, we have an interesting guest. We have an OBGYN physician from the Valley. And I think it's going to be a great show. Dr. Clint Leonard will be here. We have a veterinary medicine physician that will be on the show upcoming in the next couple of weeks. So we have some really interesting shows upcoming. So thank you for joining in and listening.
All right.
Hi, Marie here for wannasing.com. Are you looking for professional...
All right. Excellent. This concludes DocTalk Radio with Dr. Ann Borik. Till next time, I wish you health, wellness, and many blessings.
DocTalk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.